When you're writing a prescription, what's that one hidden risk that might just be flying under the radar? Well, today we're going to talk about the QT interval. It's a critical ECG measurement for sure, but it can also signal a truly life-threatening danger to our patients. So let's break down exactly what you need to know. And just so you know, this whole explainer is built on the practical wisdom from a fantastic clinical discussion led by Dr. Rajan Gupta and his team at the Newburn Knowledge Hub. We're essentially just distilling their peer-led insights to bring you the key takeaways for your own practice. And this quote from Dr. Gupta really just says it all, doesn't it? The QT interval, it's that hidden thing. It's kind of becoming as fundamental as checking for a penicillin allergy. The combinations of drugs we use every single day can create a perfect storm if we're not being careful. So what is this hidden danger exactly? Well, it all starts with really understanding what the QT interval represents in the heart's electrical cycle. The discussion we're drawing from used this brilliant analogy, and I think it just clicks. Think of the QT interval as the heart's washing machine cycle. It's the whole process, the time it takes for the ventricles to contract and then completely reset for the next beat. When it's working right, it's just this perfect rhythmic cycle. But the problems really start when that cycle gets delayed. And often, it's by medications we prescribe. This prolongation, it doesn't just slow things down. It can lead to a really catastrophic failure of the heart's rhythm. And that primary danger has a name, a life-threatening arrhythmia called torsades de pointes, or TDP. This is basically a chaotic, super-fast heartbeat that can spiral into ventricular fibrillation, which, as you know, can be fatal. And the difference is just stark. I mean, look, a normal rhythm is stable, it's predictable. But with torsades de pointes, you get this chaotic waveform that looks like a wave building up and then collapsing on itself. It's unstable, it's unpredictable, and it's incredibly dangerous. And things get critical fast. How fast? About 10 seconds. In just 10 seconds from when torsades starts, a person is probably going to faint. And if that chaotic rhythm doesn't fix itself in a minute or two, the consequences can be dire. That's the tiny window we're dealing with. Okay, to make this really hit home, let's use a medication we all know as our case study, the antidepressant Citalopram. This will help us see exactly how these risks can pop up in our day-to-day practice. Citalopram is really well known for this issue. The MHRA has issued warnings because it causes dose-dependent QT prolongation. It's simple. The higher the dose, the bigger the risk. And this is crucial, that risk just multiplies when you combine it with other drugs that do the same thing. And that brings us to the first type of dangerous interaction, pharmacodynamic. This is basically just a simple additive effect. You take one drug that prolongs the QT interval, you add another one that also prolongs it, and boom. Their effects stack up, pushing the patient right into that danger zone. The second type is pharmacokinetic. Now this one's a little sneakier. One drug might not touch the QT interval itself, but what it does do is block an enzyme that the body needs to clear another QT prolonging drug. So what happens? The second drug's levels build up, become toxic, and create the exact same dangerous effect. So, with those two mechanisms in mind, let's look at some very, very common prescriptions that become pretty hazardous when you give them alongside citalopram. First on the list is a really dangerous combo, citalopram with a macrolide antibiotic like clarithromycin. This is a classic dual-action risk. The macrolide itself prolongs the QT interval, and it blocks the enzyme the body uses to clear the citalopram. So you get a double whammy, a direct effect plus a toxic buildup. And this is exactly why the official guidance is just avoid this combination. And the list, well, it goes on. Combining citalopram with tricyclics like amitriptyline or even common antiemetics like ondansetron, that creates a synergistic effect that should be avoided. Even something as common as fluconazole requires caution because it can inhibit that clearance and send citalopram levels soaring. Okay, so we've defined the risk, we've identified some of the main culprits. Now for the most important part, what's our safety playbook? How do we actually manage this in the real world? When you get an ECG report back, your eyes probably scan over a ton of numbers. But there is one number you really need to lock onto for this risk: 500 milliseconds. Just think of this as the absolute red line. It's that critical threshold where a potential risk becomes a definite problem. We can actually break this down into a really simple rule of three, using the corrected QT, the QTC, right? So if it's below 450 milliseconds, you can generally rest easy. If it's between 450 and 500, okay, that's your yellow light. There's a potential problem and it needs investigating. But over 500, that is a definite red flag. Action is required immediately. So here's a practical 5-step strategy. 1, just be aware of the common high-risk drugs. 2, for each patient, assess the risk versus the benefit. 3, review the specifics, the dose, the duration. Remember, a single dose is way less risky than a long course. 4, just avoid combining 2 or more of these QT prolonging drugs whenever you can. And finally, number 5, if you have any doubts at all or if there are risk factors, check an ECG.
So, given everything we've just talked about, the logical next question is, are there safer alternatives we should be reaching for as our first choice?
And the answer is a resounding yes. Based on MHRA guidance, the prescribing hierarchy has really shifted. So instead of reaching for citalopram or escitalopram first, safer first-line options like sertraline and fluoxetine are now recommended, simply because they have a much lower risk of causing QT prolongation. And that leaves us with a final question for you to think about. Given its well-documented risk and the fact that we have safer alternatives, is it time to rethink the role of citalopram, maybe treating it as a second or even third-line option in our prescribing toolkit? It's a really crucial conversation, and it directly impacts our patients' safety. Thanks so much for tuning in.